Hi everyone, and welcome to our module on systemic lupus erythematosus. Systemic lupus erythematosus is also called SLE, or simply lupus for short, and it's a multi-system autoimmune disease. Most patients who have lupus, about 90%, are women, and usually the onset of the disorder is in the age range of 15 to 45 years. Lupus involves antibodies that form against nuclear material inside of cells. As a result of this, a key finding is the presence of anti-nuclear antibodies, or ANAs, in the plasma. We'll talk more about this in a few slides. Once these anti-nuclear antibodies form, they bind and form antibody-antigen complexes that circulate in the plasma. For this reason, lupus is often considered one of the classic examples of a type 3 hypersensitivity reaction. Also, as a result of the circulating complexes, you can get deposition in many different tissues, and lupus can cause symptoms in lots of different organs. For example, you can have symptoms in the joints and the skin and the brain and the kidneys, as we'll see in a few slides. Finally, much of the damage caused by the circulating antibody-antigen complexes that deposit in tissues results from activation of complement. This means that low C3 and C4 levels, or hypocomplementemia, are a key feature of lupus. You will also see a low CH50 test, and I talk about these two tests in the module on complement. But for our purposes here, I just want to point out to you that this pathophysiology leads to low levels of complement proteins. The etiology of lupus is unknown, and likely it's highly complex. There are data that genetic factors, immune system factors, and environmental factors may all play a role. There's some evidence that viruses may trigger the condition. There's also evidence that UV light may be very important. And as we'll see later, for patients with lupus, exposure to UV light can trigger a flare of the condition. Before we talk about the symptoms of lupus, let's talk about the antibodies that cause the condition. The first antibody we'll discuss are the anti-nuclear antibodies, or the ANAs. These are antibodies that are present in the serum of lupus patients. However, they're also found in 5% of normal patients, and they're also found in many other autoimmune disorders. Therefore, they are a sensitive but not a specific test for lupus. If you suspect a patient has lupus and they have a negative ANA, this makes the disease very unlikely. On your USMLE Step 1 exam, they are most likely going to tell you that the ANA is either positive or negative, but in real life, ANA testing is reported as a titer, such as 1 in 20 or 1 in 200. What this means is that they continue to dilute the sample to see whether they can detect the ANAs. If you can dilute it 200 times and still detect ANAs, this is a strongly positive test. If you can only dilute it 20 times and then the ANAs are not detectable, this is a not very positive test. Often 1 in 160 is what's considered the cutoff for a positive test, but obviously the higher the titer, the higher the concentration of ANAs in the serum. There are two other antibodies that are found in lupus patients that are much more specific for the disease. The first one is the anti-double-stranded DNA antibody. This is specific for lupus, unlike the ANA. It's also associated with disease activity. The level of anti-double-stranded DNA will rise during flares of the condition. It's also associated with renal involvement. We'll talk later about how patients with lupus can get renal involvement, especially glomerulonephritis. And if you have a high level of anti-double-stranded DNA, you're at greater risk for developing renal disease. The second specific antibody is called the anti-Smith antibody. It's named for the first person in whom the antibody was discovered. This is also specific for SLE. And it turns out that this antibody is directed against structures called small nuclear ribonuclear proteins, or SNRNPs. And there's a tie-in here with molecular biochemistry that they like to ask you about on Step 1. SNRNPs are small nuclear ribonuclear proteins. They're sometimes called SNRPs. And they're made up of RNA and protein. That's why they're called ribonuclear proteins. And they combine with RNA transcripts. RNA transcripts are pieces of RNA that have been synthesized from DNA. So those RNA pieces will combine with a SNRP and form a structure called a spliceosome. As a result of formation of a spliceosome, a portion of the RNA transcript will be removed, and this is a way in which RNA is modified before it's translated into a protein. And antibodies against SNRPs can be found in lupus, such as the anti-Smith antibody. You should be aware that the anti-Smith antibody is part of a panel of blood tests against nuclear antigens called the ENA panel. ENA stands for extractable nuclear antigens. And antibodies against ENAs include anti-Smith, as we have discussed, which is specific for lupus, but also anti-RNP, which is used to look for mixed connective tissue disease. You can also find this antibody in lupus patients and scleroderma patients. There are two anti-SS antibodies, which are relatively specific for Sjogren's syndrome, although you can also find them in lupus and scleroderma. Anti-SCL70 is found in scleroderma, and anti-Jo1 can be found in polymyositis. This panel of blood tests is often sent for patients in whom you suspect an autoimmune disorder. Now let's talk about the symptoms of lupus, and the first thing you should know is that the symptoms of lupus are not constant. Patients with this disease often have flares and then they go into a remission for a period of time. And when they experience a flare of the condition, they will have fever and weight loss and fatigue and lymphadenopathy, and all of these are symptoms of inflammation. The classic skin finding of lupus is the malar rash. The word malar means cheek, and this is a rash on the cheeks. This is a drawing of a woman with the malar rash here. It often looks like a butterfly, as it does in this woman on the screen, and so it's sometimes called a butterfly rash. It's common on exposure to sunlight, and as we'll talk about later, this is one of the reasons lupus patients often avoid the sun. There's another kind of skin lesion that patients with lupus can also get, and this is called a discoid lesion. It's a circular skin lesion, that's why it's called discoid, and it classically occurs on the forearm, not on the face. Raynaud's phenomena is another common feature of lupus. This is the result of vasospasm in arteries supplying blood to the fingertips that results in ischemia of the fingertips. Patients who have Raynaud's phenomena can develop white-blue fingertips. They can become painful, especially on exposure to the cold. Your fingers normally have some vasoconstriction on exposure to the cold, and this can trigger vasoconstriction and the Raynaud's phenomena. On the screen is a picture of someone who's got the Raynaud's phenomena. You can see that some of their fingertips are white and some are turning purple. This is from ischemia. It can lead to fingertip ulcers, sometimes called digital ulcers, that can become infected. And Raynaud's phenomena is not unique to lupus. It can be seen in many other conditions. You can have Raynaud's phenomena by itself, or you can have it secondary to other autoimmune disorders like Sjogren's syndrome or scleroderma. Other symptoms of lupus include oral or nasal ulcers. This is a picture of someone who has a mouth ulcer here. Arthritis is common. Patients with lupus during a flare will get tender, swollen joints. Another feature of lupus is serositis. This usually means inflammation of either the pleura or the pericardium. If you have inflammation of the pleura around the lungs, you can develop pain with inspiration. If you have inflammation of the pericardium, you will develop signs and symptoms of pericarditis. Another feature of lupus is what I like to call penias. So patients with lupus can develop anemia, thrombocytopenia, or leukopenia. This results from antibody attack of the cells, and this is different from the other pathophysiology of lupus. In this case, it's a type 2 hypersensitivity reaction where antibodies are directly attacking cells. Much of the other symptoms of lupus are the result of immune complex deposition in type 3 hypersensitivity. Lupus can also involve the brain. Patients with lupus can get what's called lupus cerebritis. This involves cognitive dysfunction, which consists of confusion and memory loss during flares. They can also have strokes and they can suffer seizures. Involvement of the kidneys is one of the more serious aspects of lupus. Lupus nephropathy can present as the nephritic syndrome, the nephrotic syndrome, or both, and this is a common cause of death for these patients. Diffuse proliferative glomerulonephritis is the most common lupus renal syndrome, and this usually presents as the nephritic syndrome. Lupus patients can less commonly get membranous glomerulonephritis, and this presents as the nephrotic syndrome, and I talk about both of these conditions in the renal modules. There's a rare form of endocarditis that can occur in lupus patients. It's called Libman-Sachs or Morantic endocarditis. This is non-bacterial endocarditis. It's not due to a bacterial infection. It's due to inflammation of the valves as a result of lupus. And one thing that's unique about it that they like you to know for the boards is that it classically affects both sides of the valve. If you look at this echocardiogram on the screen, you'll notice the left ventricle of this patient, and this is the mitral valve, and there is a thickness, there is a vegetation on the mitral valve here. That is this gray thing that is swinging around as the mitral valve moves. You'll notice that it's confined to one side of the valve. In this case, it's on the left atrial side. And that's the way most bacterial vegetations present. They're confined to one side of the valve, usually the atrial side of the mitral valve. What's unusual about Libman-Sachs or lupus endocarditis is that it typically involves both sides of the valve, which is usually not seen in bacterial endocarditis. Antiphospholipid antibodies are another type of antibody that can occur in association with lupus. They can also occur as a primary problem without having lupus. These are antibodies that are directed against proteins in phospholipids. That's why they're called antiphospholipid antibodies. And there are three important clinical consequences that can result from having these antibodies in your plasma. The first one is blood clots. This is called the antiphospholipid syndrome. This is when you have antiphospholipid antibodies and you develop venous or arterial thrombosis. So patients with the antiphospholipid syndrome can have DVTs and strokes. They can also have fetal loss. Women who get pregnant with these antibodies can thrombose the placenta and have recurrent fetal loss as a result of antiphospholipid antibodies. And I've bolded the word arterial thrombosis because arterial thrombosis is relatively uncommon. So people that present with strokes at an early age or thrombosis of their fingers or toes, these are the type of people you have to worry about the antiphospholipid syndrome. The other two clinical consequences of the antiphospholipid antibodies are an increased PTT and a false positive syphilis test. We'll talk more about this on the next slide. There are three clinically relevant antiphospholipid antibodies. The first one is called anticardiolipin, the second one is called the lupus anticoagulant, and the third one is called anti-beta-2 glycoprotein. The anticardiolipin antibody is the antibody responsible for the false positive syphilis screening tests RPR and VDRL. Years ago, people in the United States had to get a syphilis test before they could get married, and it was widely known that women who had lupus would test positive via these two screening tests. The reason is because syphilis produces antibodies to the RPR and VDRL antigens, but the anticardiolipin antibody also reacts with the RPR and VDRL antigens. To understand this, you need to appreciate that the RPR test or the VLDR test are really just commercial antigens. In this case, let's assume we have one of the RPR antigens and we're using it for our test. This antigen is useful for syphilis because antibodies to syphilis, which I'll just label with an S here, will react with RPR. The problem is that other antibodies will also react with RPR. So cardiolipin will also react with RPR, so will many other antibodies, and there are lots of false positives on the RPR test for this reason. The lupus anticoagulant antibody is the antibody that interferes with the PTT test. If you test the serum of someone who has the lupus anticoagulant, their PTT will be elevated. In fact, they are at great risk for blood clotting. It's not that their blood is too thin and that they are at risk for bleeding. As we discussed on the last slide, they can have thromboses. However, you get a false elevation of the PTT test caused by interference of this antibody with the test itself. So to make an official diagnosis of lupus, you need 4 of 11 criteria, and we've just gone through the 11 criteria on the last few slides. The first one is a malar rash, the second one is a discoid rash, photosensitivity is the third one, oral ulcers are another one, arthritis and serositis are 2 more, lupus cerebritis or CNS involvement is the 7th, renal involvement is the 8th. Penias, as I discussed, like anemia, thrombocytopenia, and leukopenia are the 9th. The 10th is ANA, and the 11th is another antibody test like anti-double-stranded DNA, anti-Smith, or anti-phospholipid. If you have 4 of these 11 criteria, then you can make the diagnosis of lupus. Obviously, the more criteria you have, the more secure you can be that the diagnosis is correct. There is a lupus-like syndrome that can develop after administration of certain drugs, and this is called drug-induced lupus. The 3 classic drugs to cause this are isoniazid or INH, which is a tuberculosis drug, hydralazine, which is a rarely used blood pressure drug, and procainamide, which is a rarely used antiarrhythmic. Patients who get drug-induced lupus often have symptoms like a rash and arthritis. They can have penias, and they often have a positive ANA. Importantly, the serious complications of lupus are rare, so kidney problems or CNS involvement is very rare. A key feature that's relatively unique to drug-induced lupus is the presence of antihistone antibodies. These antibodies are rarely elevated in traditional lupus, but they're commonly elevated in drug-induced lupus. And then importantly, in this condition, when you stop the drug, the syndrome goes away. If it doesn't go away, then they probably have actual lupus. Lupus flares are often treated with steroids. Other immunosuppressants are used as well to treat the condition. Patients with lupus are advised to avoid sunlight. Many of them are photosensitive and can develop a malar rash if they go out in the sun. In addition, sunlight can trigger flares of the condition. There are several important causes of death. The first one is renal failure, which I mentioned before. Infection is an important cause of death because many of these patients need to take immunosuppressant drugs. And as I told you before, they can develop leukopenia from lupus. And then finally, patients with lupus are at increased risk for coronary disease, and coronary disease is an important cause of death as well. There's a condition that occurs in newborn babies called neonatal lupus. This is very different from the lupus we've been discussing up to this point in this module. Neonatal lupus happens because maternal antibodies cross the placenta and affect the fetus. This occurs in 1 to 2% of babies born if the mom has an autoimmune disease. This can occur if the mother has lupus, but it's also very common when the mother has Sjogren's syndrome. And the reason Sjogren's syndrome is common among mothers is because the SSA-Rho or SSB-La antibodies are believed to be the ones that lead to this condition in the fetus, and these are the antibodies that are commonly elevated in Sjogren's syndrome, although they can also be elevated in lupus. If you have these antibodies for any reason, Sjogren's or lupus, your baby is at increased risk of developing neonatal lupus. The symptoms of neonatal lupus are usually present at birth or present in the first few weeks of life. One of the most obvious symptoms is the rash. This is different from the traditional malar rash of lupus. Babies with neonatal lupus get multiple red circular lesions on their face and scalp. You can Google neonatal lupus and see lots of pictures of babies who have this rash. This usually resolves in a few weeks and is not serious. What is serious is that babies with neonatal lupus often develop congenital complete heart block. This is an EKG strip showing complete heart block. Babies with this condition will have a slow heart rate in the 50s. It often does not improve with steroids, and they often require a pacemaker, which they will have to have for the rest of their life as a result of neonatal lupus. And that concludes our module on lupus.